The first and most burning question, and I apologize if someone asked it, I was outside actually meeting with a bunch of physicians from the state of Texas and the city. I mentioned Governor Rendell's suggestion on the most favorite nation type provisions, and actually the Texas legislature is going to be looking into that. I asked them they ought to come in here if there was some room. But the most pressing question, and I don't think anyone has asked it yet, but I know it's on everybody's mind, given where we are in the primaries. So I would ask both governors, if nominated, would you accept? If elected, would you serve? So you can answer that some other time instead of putting you in a hot seat. Yeah. Governor Pawlenty, I really wanted to, there are a couple of things you said, the most interesting things we've been discussing about pay for performance and such. But first, just protocols. And you're talking about the optimum care and such. How do you establish those benchmarks? I think you made reference to diabetes treatment, and you said that's easily identifiable, what you should do, what are the basics, what's proper care, best practices and such. But if you're talking about treatment across the board, whether it's a particular disease or regular treatment or whatever for other or just checkups or whatever, how do you ever get to that bottom line, first of all, as to what would be the minimum of best care, best practices? How do you establish that? And then secondly, I guess it's how do you establish pay for performance criteria? Because we've asked Governor Leavitt, Secretary of HHS, and he hasn't been able to give us an answer to that, at least the last few hearings that I have attended. So those are the two questions.
Thank you, Congressman Gonzalez. I can tell you in Minnesota, we envision this in two steps. We're not ready yet, nor are the databases ready yet, nor is the delivery system ready yet to pay purely for healthcare outcomes. The systems aren't robust enough. The medical culture is not yet advanced enough. But conceptually, we see that, and there's acceptance of it. In the meantime, as a proxy for outcomes, we want to pay for adherence to world-class standards, which gets to your point. Again, this is not the destination, but it's the pathway to the destination. We have a hometown advantage in Minnesota because we have the Mayo Clinic. And so we have the Mayo Clinic and others who've sponsored something called ICSE standards. I forget what it stands for, but it's ICSE. And it's basically a depiction of world-class standards in many courses of treatment. And so when doctors come and say, you know, why do I want to practice medicine by a cookbook? You know, I got my own standards. And like, you really want to take issue with the Mayo Clinic as being, you know, low quality? You really? And so we're not saying you have to do that, but we're saying we'll pay you more if you do it. So in the case of diabetes, we have this program called Bridges to Excellence, where we say, all right, we got about 6 or 8% of our current diabetics in Minnesota on these optimal care treatment regimes. We want to get that to 80% over the next 10 years. So we're saying to our providers, we'll pay you more if you can get your patient load to 10% next year, and then after that, 15%, and then after that. So it's a bonus system based on these ICSE standards. But I will acknowledge to you that is not the end point, because those treatment protocols or standards are proxy for better health care outcomes. They're not the outcomes themselves. So we had some resistance in Minnesota, and still do to some extent, but the medical community has come around these ICSE standards mostly. There's still some dissent, but they've mostly come around it, and mostly because of the credibility of the Mayo Clinic and the people who stand behind the standards.
Thank you very much, Governor. And
Congressman, I'll take
Governor
a quick
Rendell?
shot at that. Number one, obviously, standards are always debatable, but we know that there are certain things that we shouldn't pay for. And our Medicaid program has informed providers that we are not going to pay for medical errors anymore. We are not going to pay for obvious preventable medical errors. You know, right now in the current system, you go in for the amputation of your right arm. The hospital, by mistake, amputates your left arm. Your provider pays for that. Then for the remediation of the left arm, including the placing of a prosthesis, your provider pays for that. And then they get around to amputating the correct arm, and your provider pays for that a third time. No other business, no other field of endeavor in the United States of America would business people put up with that, paying for that type of performance. And we're not in our Medicaid program anymore. We've notified them. We've worked on it with our hospitals, and our hospitals have agreed that this is a fair system. We are not going to pay for obvious preventable medical errors. That's a standard that should be applied across the board. Secondly, we do know the industry, the science of healthcare knows what works and what doesn't work. There are 10 states, and I think Minnesota is one of them, that allow for what's called the Taylor model, named after the doctor who formulated it, for treating chronic care diseases like diabetes. Right now in Pennsylvania, if you have diabetes, the only thing we'll pay for is the time you spend with your primary care physician. Most primary care physicians are swamped. They tell you have diabetes, they'll give you a pamphlet on diet, they'll give you a quick run-through of how you test yourself. You're out of the office, and the next time they see you, maybe when you're going into the hospital for amputation. The Taylor model, the healthcare system pays for a nutritionist who works almost on a weekly or every 2-week basis with that patient, saying, how are you doing? Is your diet too restrictive? It is, I can make substitutions. The Taylor model pays for a physician's assistant who will tell that person how to test themselves, or if it's too painful, will suggest an alternate method and make sure that the patient is living up to those procedures on a weekly basis. The Taylor model pays for the pharmacist's time as well. You manage the disease. You don't just treat it. You manage it. We can show you, in the 10 states that have the Taylor model, the hospitalization rate for diabetes compared to Pennsylvania. And we estimate we will save $2.1 billion if we can get down to the hospitalization rate of the 10 states who manage chronic care diseases. So it is